We're going to talk about DI and SIDH nursing, endocrine system. Very straightforward. I'm going to make it easy as much as possible. It's a physiological adaptation question. You're going to learn this in the easiest and most simple way as much as possible. Let's get to it. What are we going to do? We're going to walk through it. Each of us is going to contribute and come up with an answer for each of the questions we're going to talk about. It's a small lecture. It's not going to be that long, but this is the way we're going to approach it. If you see this question anywhere, this is going to help you answer it. First, I'm going to give you some quick information about this topic. So in your brain, you have something we call the pituitary gland. The pituitary gland is usually below where the hypothalamus. So it's the hypothalamus. What it does is he make these ADH, right? And these get stored in the pituitary gland. Which portion of the pituitary gland? The posterior aspect of it. This is the posterior pituitary, right? It's the same location you're going to find what? Pitocin. So Pitocin actually behave like ADH. So they are in the same area of the posterior pituitary, right? That is the easiest way I can tell you about. It's part of the posterior pituitary gland in your brain. First of all, what is the function? Okay, what does it do? The function of it. What this hormone does, antidiuretic hormone, it basically go to your brain. It comes from your brain. It go to your kidney and tell your kidney, hey, I need you to reabsorb some water. So all it does is water balance. That is its function. It's going to help with water balance. That is the key. So water balance is going to concentrate your urine so that you don't have what? A diluted urine, and it keep your blood osmolarity normal as much as possible. And it's under negative feedback. That means if your blood is diluted, you will tell your body, hey, I need more water to be get rid of water so that the blood become concentrated and normal. That's all. This is the hormone function. Now, what are we going to do? We're going to do a table, and then I can explain to you what happened. First of all, what is the main issue we're talking about? We have diabetes insipidus. That's, I'll put it here. And then we have, let me put it here like that. Diabetes insipidus, right? And then you have SIDH here. And then we have the condition we're going to separate them, right? SIDH. So first of all, the first thing we're going to talk about is what is the ADH? What does it do in terms of if it's associated with DI? And then SIDH. So what is going to do? If you have ADH, it's going to absorb water. Diabetes insipidus, what is the problem? You have little, so this is too little. So I'm going to use blue. We have too little of ADH. That's his problem. In SIDH, we have too much of that. So I put it green. So too much of that. Now, what do you think? If we have we have this situation, therefore, what is the water balance issue? This is what your anklets will ask you. What is going to happen to the water balance? In water balance situation, what is going to happen? You're going to lose, we're losing a lot of water. What do you think about SIDH? What is going to happen? We have too much of ADH. Therefore, are we going to be losing water or are we going to be gaining water? We're going to do what? Gain water. So this is water retention. You're going to retain water. And so you see the picture now, we have retention of water. That's what is going to happen in this situation. So let me make that one black and then make. Now, if you're going to retain water, the next thing you should do when you're learning this is come up with this. So what do you think? I'm going to have urine output issue. And then based on the table, DI, what is going to happen? They have little ADH. ADH is supposed to hold on to water. Therefore, if you don't have the ADH, what is going to happen to your urine? Are you going to have a lot of urine, or are you going to have less urine? You can see that they don't have ADH. Therefore, their urine output is a lot. So polyuria. You see, this is the way I want you to think about it. So you have excessive. We have excessive urine. These people, they have too much ADH. Are they going to have a lot of urine? No. They're going to retain water. So when you look at them physically, what is going to happen? The DI patient, what are they going to do? Dehydrated. They look dehydrated. And these people, they have what? Fluid overload. You see the picture now? This is the way you see. This is a long lecture, but this is the easy way, right? Now I have physical exams. DI patient is dehydrated. SID patient is overloaded with fluid. Your NCLEX will want you to, or nursing school, they want you to know what is going to happen to the urine specific gravity. So urine specific gravity. Think about it. Is it going to go up in the patient with the DI, or is it going to go down? Or SIDH, is it going to go up or down? What do you think? What do you think is going to happen? If your urine is diluted, you're peeing a lot. If I'm peeing a lot in a DI patient, what is going to happen to me? My urine specific gravity, is it going to go down or up? What do you think? Put it in the answer choice in the comment section. But this is going to what? Get diluted. So it's low. How? This is your number, 1.005, right? Or you can say 1.003. That's the easy way you can think about it. And then if you want to know for SIDH, flip it, because it's going to be what? Your urine is going to be concentrated, peeing. So urine specific gravity is going to be high and it's going to be greater than that. But this is the highest it will go. This is the lowest, and the range is 1.003 to 1.030. So that is the normal range. Therefore, this will be high, greater than the highest normal, which is 1.030. Now, the next thing, when you're doing this and you're studying, don't spend a lot of time watching a lot of video. This is the easy way you go about it, and you have mastered this content. Now, always think about sodium, hyponatremia or hypernatremia. What is the sodium going to do? Then that's the next thing. Sodium, serum sodium. Is the sodium going to go up in a DI patient or low? Think about it. Go back to the pathophysiology. They're losing water. If you take a bowl of solution that has salt and water, and if you remove the water from it, you'll be left with salt. Therefore, the sodium is going to be higher in what? Serum sodium in DI. So in this situation, we have what? Hypernatremia. You see, hypernatremia. And therefore, this patient, his sodium is going to be high. But remember, it's what? Dilutional hyper, or is hypernatremia due to loss of water, but it's not like they've lost too much sodium. It's the sodium is the same, it's just the loss of water. And therefore for SIDH, it's going to be different. They're holding on to water. So they have what? Hyponatremia state. That's all. Done. The board will ask you about specific gravity. So you got to know specific gravity of your blood. It's the same thing as concentration. The strategy is whatever your sodium is doing, that is what your osmolarity is also doing. Therefore, serum osmolarity is the same direction as that of what? Sodium. So the serum osmolarity is going to be high, right? This is going to be high, and this is also going to be what? low because it's getting diluted. You getting the picture now? What do you think? Why do you have to study this? What is the purpose of this? Why do you have to learn this? NCLEX want you to know this, and that is what we call the main concern. I'm going to put it here. What is the main concern for this problem? The main concern, that means what is your prioritization, right? You see a question and it'll ask you, what should be your prioritization for a patient with what? The diabetes insipidus, who has very low ADH, and what is happening to them? What should be your concern? What should be your prioritization? This is the table, all you need. What should be your concern? What do you think? If I'm losing water and my sodium is high, what do you think is going to happen to me? Think about it. And SIDH, if you're gaining too much water and your sodium is going low, this is what the NCLEX asks you, right? So for DI, your concern is what? Hypovolemic shock. So dehydration and shock. So this one, shock and hypovolemic, right? Dehydration. I guess I'll put dehydration. In SIDH, the sodium is getting lower and lower and lower. So your priority, the next intervention, what the NCLEX will ask you or nursing school, what should you prioritize in everything is about what? Cerebral edema. Your brain is going to swell. So I have swelling of the brain. I have seizure. Like I said, adapting class is very simple, form of simplicity. I try to like simplify things as much as possible so that it become easy, relatable. This is all why they ask you this kind of question, so that when you're taking care of a patient, you know that I have to worry about shock in a GI patient because they're losing water. And if it's a SIDH, my prioritization is what? Seizure or cerebral edema. That's all. Now, what are you going to do? Think about it. The treatment is the last thing. What are you going to do? Now that you know the problem, we got to treat it. So I'm going to put the treatment up here like that. Treatment. You got to bring your fundamentals, fluid and electrolytes here, right? One person is losing a lot of fluid and another person is gaining a lot of fluid. But what is the fluid? It's just water. Therefore, and one sodium is high, the other one is low. DI, the sodium is what? Elevated. Is therefore, and therefore, we should try to bring it down to normal as much as possible. The other thing too is they don't have ADH. That's why they're acting like that. Therefore, whenever they give you a question and they ask you, how do you treat the patient? Pharmacology, give them what they need. A DI patient, what do they need? They need ADH. So we give them ADH, and therefore that's what we're going to give them. We're going to give them ADH, and then rehydrate them. Unfortunately, there's no ADH, so they get the desmopressin. And then you rehydrate them. Rehydration means you give them fluid, right? You give them back the fluid. So they need free water, not sodium, or half normal saline, right? Free water or half normal to dilute their sodium. For SIDH, well, they have too much ADH. Therefore, we don't need to give them ADH anymore. What are we going to do? We're going to block the ADH. So know this pharmacology. There is a medication for that. It's called demiclocycline. That's the medication you should know. This is very important. This is how you can block the ADH. There's another one. You start with the last name Vaptan. Don't worry about anything in front of it. Know that their last name is Vaptan. I can give you one. It's called Connie Vaptan. But know the last name and you can distinguish between them. Therefore, if they give you a patient who has SIDH and you don't see demiclocycline, which block ADH, you can give them anything associated with Vaptan, and that can block ADH, and that will help with that. Remember, they are fluid overloaded. Therefore, we're going to restrict them from drinking. And because they're going to have seizures, what are we going to do? Give them hypertonic saline, 3%, so that they don't have seizures. This is all you need for SIDH and DI. There's one more, advanced level, thinking one. This is where, if you know this, it's the basis, but there's advanced one. But this is a table. I want you to reproduce it. Don't memorize it. Sit down and do the table, and then go through each steps and see how much you can recollect. When you do that, that means you master this topic no matter what they give you. But you see this in physiological adaptation, the complication associated with it, or they can give you a case study and you got to manage it. You see there's a fluid electrolyte issue, there's sodium here, osmolarity issue, dehydration start, and how to replace fluid. This is a straightforward question that when you see it, don't let the NCLEX and take it from you. This is all you need. Now let's get to the advanced level that you have to know to baffle yourself, that you'll be a little bit ahead with the average student, so that when they ask that kind of question, you can answer it. But this table, I want you to reproduce it as much as possible. Now, let's clean everything and go back to the advanced level. You have to know the causes of it. I explained to you that the hypothalamus is sitting here like that, and the pituitary is a certain organ that sits here like that. There's nerves that come through the pituitary like that, and that is where most of the ADH. So if this is the posterior pituitary, anterior pituitary, you have ADH here, you have pitocin here. And anterior is you have other hormones, steroids, you have sex hormones and other things, prolactin. The problem is these nerves can get destroyed. They get into trouble. And so the causes of this is very common for both SIDH and DI. Most of them can be caused by infection. Infection alone can do that. Or if they have surgery. When you have surgery, you disrupt the nerve and you kill them. Or if you have head injury, trauma, you can develop diabetes insipidus or SIDH, syndrome of inappropriate secretion of ADH. Just note that those are very, very common for both of them. It's very, very common. But then there's a distinguishing fact. When you have a DI, I'll put it here, in the SIDH. The DI, there's certain things that can cause that. SIDH, especially if you have small cell lung cancer, watch for that. NCLEX will give you small cell lung cancer. It's most common. Anything that out of your brain that can do that, small cell lung cancer. That's the one you should know about. For DI, I want you to know two things. There's two things I want you to know. There is a central one, and then there's a nephrogenic. That means central is coming from your brain or is from your kidney, because your kidney is what is responsible. If this is your kidney, the ADH go to your kidney and they absorb the fluid. Therefore, the nephrogenic means your kidney, right? Nephrogenic. Versus central. Central means it's from your brain. That means your brain is not working, right? And what is the problem? They're lacking ADH. So you see, there's no ADH, negative ADH. That means your brain is what is causing the problem, and this is your kidney. In the nephrogenic one, you have ADH. So you can call it plus ADH. I have ADH, but it does not work. In central, you don't have ADH. If you see questions like that, that is a little bit difficult. This is the problem. Diabetes insipidus can be two. It can be central or nephrogenic, right? That means nephrogenic means you have ADH in your blood, but when you go to the kidney does not see it. So the mnemonic is what? Kidney ignore it. So I want you to write this down. In that, and diabetes insipidus, which is nephrogenic, the mnemonic is kidney ignore. In central, you call it what? Can't make it. You can't make it. Therefore, you don't have it, but you can have it, and the kidney will ignore it. That is the difference. There is a medication that can cause nephrogenic diabetes insipidus, which you know, and your NCLEX will ask you. This is lithium 4 over here. Lithium is number one. That's why when you take lithium, we tell you to drink a lot of water because it makes you lose a lot of water, lose your sodium, you get dehydrated, and you have lithium toxicity. This is the reason why they're teaching the pathophysiology of teaching the patient to maintain sodium and hydrate themselves because lithium causes nephrogenic diabetes insipidus, and you lose a lot of water, and you have lithium toxicity. Lithium want to do you bad, and because it want to do you bad, it makes you lose your water. But we are very smart to teach you to prevent lithium from making you bad. That's the concept. And the central one, basically, you don't have the ADH. There's a medication that can also mimic that. SSRI can cause SIDH. So this is the whole picture about the treatment, the key fact about the difference between diabetes insipidus, SIDH, what? Nursing. And this, when you see this question, you should ace it. This is how I can present it to you in the most simple and a straightforward way. This is subscribe by request. Very straightforward. And this is the difference. Make a table, compare them, know the key fact, and never forget these two, the difference between nephrogenic and diabetes insipidus. When you see your question, use it to answer it. These are Dr. NCLEX. Thank you for watching. If this video helped you, just put a little bit of comment and so that we can grow this channel. Take care of yourself. And if you need more, check out Dr. NCLEX for content like that. Good luck in your exams. Best of luck. Bye.